operating, you are the one carrying the time. You know, you're sort of like leading the team, and you are the surgeon, you are the head of the team. You are also concerned about the time, so it is easy to forget, and more so if you enter into a very difficult procedure.
Okay.
So if you do 1 hour, you have a safety margin of 30 minutes that you can easily remember and be able to adjust your tourniquet. Now, that is one approach. Then the other approach is the 10-minute interval, that every 10 minutes, you release the tourniquet for 2 minutes, and then you reapply it again. But these are for tourniquets which are automated or pump tourniquets, because you can easily deflate it, rest a bit, and then you inflate it. You can actually be doing it yourself as the surgeon, but we don't have those type of tourniquets. Usually what we use as the tying rubber tourniquets, and you have to ask someone to adjust this for you. So personally, I use a maximum of 1 hour, and that is from the time of application. After that, the tourniquet has to be released for 10 minutes, and then you reapply it again. Yeah. Then two, on the issues of skin traction, as the presenter said, basically this is for pelvic fractures, long limb fractures, okay, and also for children. Now, for skin traction is good because it can be easily applied before you provide the definitive treatment, which most likely right now is either using nails or plates. But before you can easily apply your plates or pins or what we call definitive treatment. The patient can have a skin traction. The presenter didn't go into the details of fracture healing, but traction and separation of the proximal and distal ends allows for hematoma formation, which hematoma is then invaded by new osteocytes for new bone formation. So proper traction and separation of the proximal and distal ends initiates the healing process for a fracture. That's why we recommend skin traction as early as possible before you give the patient definitive treatment. But it is applicable for pelvic fractures, fractures of long bones, and among children. In children, it is almost the principle. Why? Because you don't want to interfere with the epiphyseal plates, whereby passing pins and other things. So that's why we use skin traction a lot in children. Then the other one is the issue of a catheter in pelvic injuries. If the patient has had a pelvic injury and they can pass urine, then you don't need to put a catheter. If the patient is, well, the pelvic is fractured, the patient is immobilized, okay, they are wetting the bed, then what we recommend are the condom catheters. But we don't have these in our setting, but that's what we would recommend. Now, if the patient has had a pelvic fracture and they have retention of urine, then the best option is to put a suprapubic catheter. They will either have a urethral injury, okay, with a hematoma or a clot blocking the urethra, or they have a spinal injury. But for safety, it is better to put a suprapubic catheter, because trying to pass a urethral catheter, you may disrupt or injure the urethra more. So it is better to pass a suprapubic catheter, then allow for spontaneous healing. And once the patient has resumed passing urine normally, then you can remove your suprapubic catheter. Okay, so that is the sort of practice for these issues that Abubakar has raised. Thank you. Okay, Dr. John, do you have any comments to the presentation?
Thank you, Dr. Alphonsus, and thank you, Dr. Abubakar, for the presentation. Indeed, it is a very wide topic and requires further reading, especially in the areas of management of fractures, which I think we need to understand more. The areas of managing nerve injuries, which has not been given due attention, and blood vessel injuries, and compartment syndrome, and the mangled extremities. But we have got a good start for further reading, and I believe it is very helpful that we have had this discussion. I thank you.
Thank you very much, Dr. John. We have colleagues on the talk. I see Tony. Tony, do you have any comments? Maybe Tony is not there. Fair, Mwigulu Fair.
Okay, thank you, Professor. Maybe my comment or some supplementation. How about the musculoskeletal injury which are resulting from burn injury? The approach is still the same for burn injury, or there is another one? Thank you.
Sebastian, do you want to respond right away?
Yes.
Hello, Sebastian? Yes, so maybe to save time, the presenter has dealt a lot with mechanical trauma. That has been the essence of his presentation. But what Fair reminds us is that injury is beyond mechanical trauma. Like he has mentioned the instance of burns, which are a form of trauma. But in this form of trauma, then you focus on the burns affecting the soft tissues. So then you apply the principles of ATLS, as Dr. John told us a day on Tuesday, and then the specific burns management, okay? But what we have dealt with today is the mechanical trauma, which usually involves road traffic crash or high velocity injuries with gunshot wounds or cuts, okay, or blunt injuries causing musculoskeletal injury. And that's why the presenter dealt a lot on the mechanism of injury. It is this mechanism of injury that is going to help you decide your interventional plan. Although the presenter dealt a lot with the mechanism of trauma, which would be applied in a road traffic crash, either it's a head-on collision, maybe people are driving in a car and it overturns, someone is pedestrian and knocked by a car, someone is riding a bicycle, motorcycle, and is hit by a vehicle. Someone is driving in a car, gets a crash, some are thrown out of the vehicle, others are retained within the vehicle. A passenger being driven on a boda, on a motorcycle, and both of these get a collision with a car or a collision with another motorcycle, the severity of injury between these two patients is different. So that's why we are interested in this mechanism of injury. And a person who sustains burns in a house will not suffer the same injuries as a person who is burnt by acid, or a person who sets himself or her on fire. So, but this just emphasizes the importance of the mechanism of injury. It will sort of direct you on how to proceed with patient management and how to focus your interventions. Thank you. So let me take a few minutes to make general comments about the topic, musculoskeletal trauma, basically focusing on the muscles and the skeletal tissues, which are the bones. Now, the presenter told us about the epidemiology of musculoskeletal injuries or trauma. But again, this data is basically dependent on road traffic crashes. That's where a lot of information has been produced. And actually, even we have some data that the presenter quoted from Uganda. And definitely, if you go back to your local settings where you are for the team in Mubende and those and the other sites, you can look at the local patterns of injuries, musculoskeletal injuries in your setting. And largely in Uganda right now, most of these are road traffic crash, and the boda cyclists contribute a very high percentage of musculoskeletal trauma that we see. Even in Mubende per se, they have the previous reports that we have generated show that these are the highest causes of musculoskeletal injuries in our setting. But once we are faced with these patients, we have to remember the talk that Dr. John gave us about the advanced trauma and life support assessment, the ATLS. Now, and as we had in that lecture, that we have the primary survey and we have the secondary survey. Then the reason why we are doing this ATLS is to identify the life-threatening injuries. Now, for us at our level as SHOs, we have to know what are the life-threatening injuries or life-threatening findings or conditions in such patients. You need to know that this is a danger sign in this patient, okay? And all this you can easily identify through your primary survey. But then as an SHO, again, it requires you to have the skill of intervention. Okay, if a patient has a pneumothorax, what can you do? Can you do the needle decompression, as Dr. John told us? And remember, as he mentioned, that formerly we have been talking about the second intercostal space, interclavicular, midclavicular line, but now the new teaching is the fifth intercostal space, mid-axillary line. But as I advise you is to read about the systemic studies, system studies which have been done to compare these two. The new approach, the fifth intercostal space, the new intervention, basically recommended by the military. A lot of these ATLS principles are coming from the US military. They are doing a lot of research on trauma because their armies are involved a lot in the world. So this recommendation comes from the military. And it is basically because of the access. When they have these body armors, which are protecting the anterior chest wall, because it is easier to be shot anteriorly. If you have a colleague in the field who has sustained injury and needs a needle thoracentesis, it is easier to go in the mid-axillary line on the lateral side with less body armor than in the anterior part because of the body armor. Okay, and the same space, that space, well, it is good, it has less muscle, easy accessible. It is also easy for doing the under-outer seal drain. So do you know how to do the needle thoracentesis? Have you done it before? Can you done an under-outer seal drain? Okay. Can you do a peritoneal lavage? Can you do focused sonography for trauma? Can you do splinting for the fractures? In many occasions, as you come to the ward, you find patients there with fractured limbs and lying on the mattresses. And everybody's saying, no, we cannot put a splint. We don't have POP. So in circumstances where you don't have the utilities, you have to be innovative, because splinting of fractures is very, very important. It reduces pain. It reduces exsanguination, and it also reduces embolization, because fractures which are not mobilized can easily form emboli. So it is important that as a doctor in charge of the emergency, you have these skills on your hands. You can easily splint a limb. You can easily apply a traction on the limb, a skin traction. It's very easy to apply, but you have to know. You have to know the skill. Do you know how to do venous cut down as an SHO? Okay. So these are the skills that I want to relate. On Monday, when Dr. John gave us the talk, we spoke a lot of broadly about ATLS. But now, when we come to musculoskeletal trauma, we want to look at the applications that we need to bring into the emergency as we attend to these patients. And these are skills that I would like you to cross-check yourselves, okay? And at times they're also asked as short questions, okay? So you need to know the skill, the theory behind it, and also the potential, the capacity for you to perform this skill as well. But definitely the needle thoracentesis you should be able to perform in the emergency, like in Movende, you have so many patients of trauma, maybe focused sonography for trauma. This one you may not easily see, but I would advise those who have active ultrasound services to go to the ultrasound. It is a very simple skill that you can learn in one day, how to handle the probe and what to look for in these pouches. Performing an under-outer seal, this one you are going to do, and I know many of you have practiced this. Splinting of fractures, there are so many patients with fractures, so you should learn to know how to put a splint and how to apply traction. Maybe something that you may not see commonly are the tracheostomies and cricothyroidotomies. We don't perform this so commonly, but for those of you who may work in very busy centers, again, you'll find that this is some of the things that you need to know, but you need to know the skill on how to perform tracheostomies and cricothyroidotomies. So that one goes back to the ATLS primary survey and then the secondary survey and those interventions that you need you need to know. So when we do the primary survey, we identify the life-threatening conditions that could help us in salvaging the patient. We do the secondary survey where we do the total body assessment, head to toe, as Dr. John told us, with full exposure. And then we do the necessary investigations like the X-rays, we do the abdominal scans, we do the CTs, so to be able to have a more definitive diagnosis in the patient. And then we do continuous reassessment. So we are assuming now that we have stabilized the patient and we have a patient who has a crushed lower limb, a crushed hand, okay? And that's where the principles that Dr. Sebastian has taken us through are important today. We want to define the area of injury, okay? Is it a lower limb musculoskeletal trauma? Is it a pelvic injury, or it is an upper limb injury? And this includes both the long bones, the short bones, and also the joints. He has taken us through some of the classifications or slides that had some of the classifications, like the Gustillo classification that basically is used for limb fractures. He has told us about the Young classification for pelvic fractures. These are important because they are going to help you in deciding on what management, because different classifications mean different mechanisms of injury. The force and direction of injury, sort of, there is a relationship between the classification, severity of injury, and the mechanism of injury. But basically, when you have limb fractures, again, he went through with these principles. The severity of injury, is it a crush wound? Okay. Do we have a compartment syndrome in this limb? So once you are in the emergency, you look at the limb and say, what is the state of this limb? Is the limb viable or not viable? Okay. Are there factors threatening the viability of the limb, like a compartment syndrome or a crush injury? Okay. And this is where proper surgical debridement is important. I don't know that you have a lecture on wound debridement, but it's a very important topic when we talk about trauma, to be able to clean the wound properly, remove all the foreign bodies, and then you debride the wound to remove all the redundant, dead, or necrotic tissues. And then if you have a compartment syndrome, the presenter went through the different parameters for compartment syndrome and the fasciotomies that you need to do. And I want to assure you, these are conditions that you are going to meet in the emergency, that you can be able to perform the different procedures. Definite debridement is something that you are going to do. Releasing of compartment syndromes, this is again something that you are going to perform. And then if the limb is badly crushed, if the limb is not viable, then you have the resort of either performing a disarticulation and then performing an amputation And again, these are somehow specific. There are specific details on how to perform these procedures. But if the limb cannot be salvaged, then those are the options of disarticulation or amputation. But you need to know the skills on how to perform this. Dr. John briefly mentioned about the nerve injuries, which we shouldn't forget, okay? And as you know that nerves, they once they are injured, they take very, very long to heal. Vascular injuries, if they are major vascular injuries, you must know how to achieve hemostasis. Basically, what we do is compression, and then maybe referral to a center where this can be properly repaired. But I would advise that you learn a few skills on vascular repairs, at least how to anastomose a blood vessel. This is something that would be very helpful for you. I don't know that you have a surgical skill, an advanced surgical skill for postgraduates. But if it is not something that you have, I think we need to arrange for that, because that's where like these skills on vascular repair can be taught. And you can actually make use of them at some point. It is easy to do, but you have to know how to do it and what materials do you need to do it. The other skill that you need is tendon repairs. You'll get many of these patients with cut wounds. Like in Mubende, it is one of the main causes of trauma, cuts. And, all sorts of tendons are taught. But as an SHO, you must know how to repair tendons so that you can get proper resumption of functionality of the affected limbs. So techniques that maybe we shall focus on are repairing of tendons, vascular injuries, okay, and nerve injuries. But nerves, even if repaired, they take very long to heal. Performing a peritoneal lavage, this one, most likely many of you will definitely know, but maybe you may need to show you how to perform the venous cut downs, because most likely many of you have not had exposure to that. Now, in centers where you have functional orthopedic teams, it is good in Mubende you have an orthopedic surgeon who visits on some days. Try to work with him to learn a few principles on fracture management, like putting the plates, doing the traction, work with the clinical teams on how to apply casts and windows. These are skills that you need to learn as part of your management for musculoskeletal trauma. And I hope the other colleagues also in the other centers have a chance to learn from those centers. But in Mubende, I think you have a bit of luck that you have a very active ortho team. At least you can learn how to read the x-rays. You can learn how to apply the appropriate managements, either using a cast, traction, or if patients need nailing or pins or plates, at least you have an opportunity to learn a few of these things. Allow me to stop there for today. I thank you once again for being available for this lecture. Thank you again. We can meet again with Dr. Abubakar when he speaks to us on pediatric trauma. Definitely there are a few specific things about pediatrics, but we shall discuss a bit more. But that will sort of bring us, would like to have a whole picture now of the whole trauma scenario. And maybe as I end, right now as we speak about the general principles of care, but in the clinical application, we are going to be meeting scenarios. For example, a 16-year-old girl who presents at the emergency following a road traffic crash. Maybe she was hit by a car and she's fully conscious with a 15 out of 15 GCS, but has respiratory rate of 30 breaths per minute and a blood pressure of 60 out of 40. What is your primary survey intervention in this case? And if section B said, when we did a secondary survey, we find that the patient has a pelvic fracture as well as a fractured humerus on the left side. What are your secondary interventions? So we would like to use this lecture to shift our mind from the tutorials are giving us guidance on what to do, but now we want to take this picture into the emergency where we are supposed to meet the patient. So we would like to see that by tomorrow, we can easily move our mind from the principles that we have learned and take these principles onto managing the patient. Thank you very much. So let me wish you a good day, and we shall meet again tomorrow at 8. Thank you.
Thank you, Professor.